Hello everyone. Welcome to another episode of Let's Talk Health. Today, we have with us Dr. Mithun Murli, consultant radiation oncologist, American Oncology Institute at BMH, Kozhikode. Welcome, doctor. So, doctor, what is the Department of Radiotherapy about?
Okay, so broadly, if you talk about oncology can be divided into three major divisions. So first is surgical oncology, who obviously deals with the surgery or oncological surgeries, etc. Then comes the Department of Medical Oncology, who deals with chemotherapy, immunotherapy, etc. Then comes us, the radiation oncologist, who deals with radiotherapy. And by radiotherapy, we'll be using in our treatment X-rays, mostly X-rays. So the doctors in the radiodiagnosis department or the radiology department, they also use X-rays for the CT scan, etc. But the difference between the X-rays that we use in radiotherapy treatment and the X-rays that they use in diagnostic procedures are that the X-rays that they are using are in terms of kilovoltage, and the X-rays that we use for radiation treatments are in terms of megavoltage. So these are much stronger than the X-rays that are used in CT scan, etc. And these X-rays, they can cause damage to the DNA of the tumor by causing either direct or an indirect damage, and that can lead to the cancer cell kill. And that is how actually radiation treatment is effective in oncology.
Do all cancer patients require therapy?
First thing is that for all cancer patients, we would actually stage the patient initially during workup. So after staging, broadly the almost all cancers can be staged into either stage 1 to stage 4. So the initial 3 stages, that is stage 1 to stage 3, these are stages where we can actually go for a curative treatment. And in stage 4, actually the disease might have spread to other structures in the body, so the patient may not have an option to get cured of the disease. So here we call the treatment to be palliative. So the aim in a palliative treatment is to get rid of the patient of his symptoms, like pain or whatever symptom he's having. Our aim is to relieve him of the symptoms, and not a curative approach. So when it comes to a radical setting or a curative setting, maybe about 50 to 60% of the patients may need radiotherapy at some point of time in their treatment. In terms of palliative treatments, about 80 to 90% of the patients may need RT at some point. Okay, and again RT may depend upon the site and stage of the disease also. Like for example, in most of the CM breast patients, like if they are undergoing breast conservation surgery, they will obviously need RT. But not all breast cancer patients need RT. And if you take CA colon, actually there's no role for RT in a radical setting, because the main treatment is surgery and chemotherapy. So need of RT depends, it may depend upon the stage, the site, and whether the disease is actually radical or a curative approach, etc. So,
can radiation and chemotherapy be given together?
Yes, of course. When radiation and chemotherapy are given together, it is called concurrent chemoradiotherapy. And that actually depends, not all patients need concurrent chemoradiotherapy. Some patients may need either chemotherapy alone, some patients may need either radiotherapy alone, some patients may need both, and that may occur either simultaneously, which is called concurrent chemoradiotherapy, or it may be sequential, that is radiotherapy after chemotherapy, or vice versa also. So that is called sequential chemoradiotherapy. That depends on the stage of the patient, the type of cancer patient is having, etc.
How long does radiation treatment last?
Okay. Again, to answer that question, like we go back to our broad division of oncology patients into either a radical approach or a palliative approach. For a palliative approach, like I said, our aim is to get rid of the patient of his symptoms. And the palliative treatment usually, it may last from either 1 day to maybe 5 days, or usually a maximum of 10 days, not beyond that. And usually the doses are much lower in case of a palliative treatment, because when the treatment doses go higher, there's like possibility of side effects. So our aim is to actually improve the quality of life of the patient, get rid of his symptoms, etc. So this treatment may take to maximum of up to 10 days. In a radical or curative approach, the treatment may again it can go up to even 1 month. it actually depends on the site, the stage, etc. But on an average, usually this treatment takes about 1 month. Usually we give one radiation per day for a maximum of 5 radiations per week. That is 1 radiation per day, 5 radiations per week. From Monday to Friday, we give 1 radiation per day. So 5 radiations per week for maybe around 1 month on an average, but treatment may even go up to 1.5 months. And there are cases where the treatment may get over within 1 or 2 weeks also. So that again depends on like the state of the patient and logistical reasons, etc. I mean, there are multiple radiation fractionation regimens that can be applied.
What are the different types of radiation?
Broadly, radiation can be actually divided into brachytherapy and teletherapy. Teletherapy or external beam radiotherapy. And as the name suggests, brachy means short distance. So the radioactive source or it will be placed either very close to the body of the patient or maybe even inside the patient. Teletherapy or external beam radiotherapy means the radioactive source is at a distance from the patient. So that is the more commonly used type of radiation, external beam radiation. And in our setting, we usually have 2 types of teleradiotherapy. Basically, that is the we have the machines using a radioactive source, which is the cobalt-60 machine, and we have the modern linear accelerators where there is no radioactive element as such, and X-rays are used instead of gamma rays as in a cobalt unit.
What are the side effects of this therapy?
Like for any treatment where there is an effect, there will be side effect. So, and again, like if you divide the patients into a palliative and a radical approach, for palliative patient, our aim is to anyway like not to cause more harm to the patient. So the dose will be much less, and mostly we won't be having much side effects for a patient who's undergoing palliative treatment. Usually he won't be having much side effect because the doses will be on the much lower side. But when it comes to a radical approach, the first thing that like we need to understand is that in the field of radiation oncology, it's always a balance between the dose given to the tumor cells and the dose given to the normal cells. So the tumor cells, we want to give maximum dose as much as possible, and for the normal tissue, they should be receiving the lowest dose, as much as lowest dose that should be achieved to the normal tissues. So that is our aim. So we have to always keep a balance. And what happens when the normal tissues receive doses that, like you asked, side effects are going to happen. So in a radical approach, we want the patient to be cured of the disease. So we have to take that risk of like patient may be having some side effect, but so that he gets the cure. So we go to much higher doses in a radical approach. And the side effects, they depend on the stage of the disease, the site of the disease, etc. Like mostly some of the most common like cancers sites we treat are the like CA breast or CA rectum, etc. So for CA breast, usually when you give radiation to the breast, the skin of the breast may undergo some skin discoloration. Some patients may like complain of itching, and some patients like for example like obese patients or who have multiple other comorbidities such as diabetes, hypertension, etc. They may have ulceration of the skin, and in the long term, the patient may also have during radiation to the breast, patient may receive some dose to the lung, and if the left side breast is being treated, some dose to the side very heart also. So the patient may have in the future some lung symptoms or cardiac symptoms, etc. But usually CA breast is somewhat a safe area to be treated with radiation. One of the area that is a bit challenging to us as a radiation oncologist is the head and neck, because in India the use of tobacco, the oral tobacco, smoking, etc. These are on the somewhat higher side. So we come across a lot of oral cavity cancer, CA tongue, mucosa, etc. So these are on the much higher side that we see in our country. So this area, when we give radiation, patient will have some side effects like dryness in the mouth, ulcer in the mouth, ulcer on the skin, and difficulty in swallowing, etc. the one thing or the major thing that patient and bystanders should understand is that all these side effects are actually transient. Usually, this come, like I said, in head and neck, usually treatment will go up to 6 weeks. That is 1.5 month treatment will be taking. So side effects set in about 2 to 3 weeks after starting RT. Then they increase towards the end of RT, and by the end of RT, patient will have his most symptoms. And during these symptoms, we will give him medicines to control whatever symptoms he's having. If it's pain, we'll give him analgesics to control the pain. If he's having dryness of mouth, we'll give him mouthwashes, etc. to control those symptoms, etc. So whatever symptom the patient is having, it will be taken care of. And after the completion of RT, then the side effects started to come down. And by about 1 month after RT, mostly the side effects, they'll come down to very less, like about 20% of the symptom that he was having. Actually, it will come to baseline.
So doctor, as we conclude, can you give a message to the public on radiation therapy?
Radiation therapy has been and still continues to be one of the major part of the treatment in an oncology setting. And the advice I would like to give to the patient and bystanders is that radiation treatment is not something that you need to be like afraid of, because yes, there are side effects to the treatment, but these side effects will be well taken care of. And because we have much newer machines now available in the field of radiation oncology, these side effects are nothing to be like feared of, like compared to what we used to have about 10 to 20 years ago. And one more thing that I would like to add is that however advanced our treatment may be, whether in terms of surgery, radiation or chemotherapy, still the cornerstone of cancer treatment is an early detection and early treatment. So that has to be the single take-home message that you should understand after this episode.
Thank you so much, doctor. So with that, we wind up today's episode. We'll be coming with another topic the next day. Thank you all for watching.